Dr. Charles O'Ham. I'm an interventional cardiologist in Wisconsin at Holy Family Memorial Hospital, and I also represent as an associate of the Midwest Cardiovascular Research Foundation, the IQ-CATEGORIZE investigators. This stands for intravascular ultrasound, quantitative coronary angiographic evaluation to effectively gauge under-recognized lesions. We have two studies. We're presenting a late-breaking trial with the hidden lesion study and a second poster abstract, which may even be more valuable as a precision plaque predictor severity study. The two are complementary, and to take one without the other perhaps is not as effective. Our goal was to improve the characterization of lesions, and in producing this goal, we recognize that lesions have four dimensions. They have length, they have height, they have depth, which is not seen on a single view angiogram, and they also vary in time. Quantitative angiography captures some of that time variation that in the traditional full-speed angiography was missed and led to the original technique being only perhaps as much as 50% effective. But single-view quantitative coronary angiography is limited as well. To improve upon that, people have done intravascular ultrasound, but that is not a technique that is easily done. It requires invasive evaluation of a vessel and could lead to potential complications. But as part of our study, we use the intravascular ultrasound as a benchmark. But in approaching that, we realized that there were limitations in the data between the intravascular ultrasound and comparative physiologic tests such as fractional flow reserve. We organized that data and made it at least interpretable and realized that, for one, vessel size specific criteria are needed to more effectively use intravascular ultrasound by the current criteria, and provided some insight into that. And in addition, we learned along the way that percent plaque stenosis above 70% was accurate across all vessel sizes from a physiologic standpoint, such that IVUS could be used as a more effective benchmark of physiologic significance. But that is not the purpose of the study, that is the background. We also realized that in the left main status of vessels, that 67% plaque was also physiologically significant. We use these reference ranges as the basis of our study and use intravascular ultrasound to compare to what could be achieved by two-view quantitative coronary angiography. In our study, we realized that in the hidden lesion study, that if a catheter was used as a quantitative coronary angiographic measure, if the catheter was a 6 French catheter and the lumen was less in 2 angiographic views than the average of the catheter of 2 millimeters, in 2 angiographic views 35 to 90 degrees apart, that the lesion would be significant from the standpoint of having high-grade plaque in vessels between 2.5 and 4.5 millimeters. We similarly modeled an 8 French catheter for the left main, which if the lesion in the left main was less than the size of the average view of this 8 French catheter in 2 angulations, that we would have a high-grade left main. These markers serve as a sort of astronomer's viewfinder to pinpoint the areas of interest where high-grade lesions may be hiding in diffusely diseased reference vessels, which is the Achilles heel of traditional angiography, as is its variation in time. By exposing these other two dimensions, we have demonstrated 40% or more improvement in the angiographic assessment without the need for potential intravascular ultrasound benchmarking. We use that as our gold standard and prove that without intravascular ultrasound, we could still do a very effective angiogram with 85 to 95% accuracy as a potential improvement in the quality of angiography that's done every day in the cath lab. Along these lines, the poster abstract looked at the severity of the plaque, and by adjusting for reference vessel disease, we were able to come up with an evaluation within 5 to 10% of the plaque, 9 times out of 10 or higher, provided specific criteria were followed as we have done in our overall study. So we suggest that these criteria may be very helpful in improving the diagnostic experience for the patient, for the angiographer, and for the benefit of both in terms of quote right-sizing care. We would hope that this would be a basis for more effective evaluation of lesions and potentially not leaving patients untreated for lesions that may be significant. But by the same token, we defer to physiologic appropriate evaluation and appropriateness criteria to decide whether those things are treated, but that is beyond the limits of our study. We're at least providing a guide as to where to look.